This one specifies pulmonary TB because tuberculosis can also affect other body systems besides the lungs. What we're talking about, of course, is pulmonary TB. So it's a worldwide communicable disease. It's close to home now because of international travel. So people like me come from a country that has TB endemics. So we carry the TB here. Now, this is a slow growing organism. So after exposure, if you have the risk factors, usually it takes about 10 weeks before you get the disease. It comes in two forms. TB can be latent or inactive, or the other one, of course, is active pulmonary TB. Latent TB means the patient has the disease, but they're not symptomatic and therefore they are not contagious. So this is the bulk or majority of the cases. Most people have latent TB. They don't even know that they have it unless they get tested. Active TB is only a smaller population, 546. And these are the ones that we're going to be seeing in the hospital because they have symptoms, they are contagious, so we see them a few days in the hospital and then they get discharged. How do we get it? First of all, let's look at who are at risk. Okay, so this is aerosolized. The organism is less than 5 microns in diameter, so it lingers through the air. So it's spread by aerosol, so airborne. It will fly through the air. Let's say one of us have TB here. It will be easily carried through the air. Simply breathing the same air as the infected person can transmit the disease. So how is it transmitted? How does it leave the host? Through talking, sneezing, laughing, or singing. Now, once it enters the patient's lungs, it will burrow into the lung tissue. So there it will hide. It's so small and it grows so slow. So an organism like that, is it easy or hard to treat? Yeah, because it's so tiny and it's very slow growing. So by the time you develop symptoms, has it already spread throughout the lung tissue? Yes, it has. So therefore, we need to treat it with multiple antibiotics and for a long duration as well. We'll get to the treatment later. So here's the answer to the question, who gets TB? Now, not everybody will get TB. Chart 1910 gives you who are at risk. Number one, if you live someone with active TB, again, emphasis is on active because is latent TB contagious? No, no symptoms. That means you're latent, then you are not contagious. Immunocompromised people. Who are immunocompromised? So HIV or AIDS patients, cancer patients, transplant recipients, or other people who are taking steroids for some sort of autoimmune disorder or after receiving a solid organ transplant. Substance abusers. Now, it's not really the substance abuse that's meaning, how is TB spread again? Aerosol, airborne. So when it says here IV drug users, it's not really saying that you get TB through the needle. Okay, that's not what it's saying. This is saying, what do IV drug users do? I mean, where do they and who do they hang out with?
Of the IV drug users?
Who may have
HIV.
Okay. So who may have TB? Okay, that's what I was gonna say, not HIV. What about these people? What's wrong with homeless people?
They don't have
Why are they Okay, so they're usually at risk for
TB.
okay, other infections as well besides TB because they are exposed to the elements. Okay, so that will compromise the immune system, right, to some extent. And again, they hang out usually with or with infected people. Okay. Those with pre-existing medical conditions, so diabetics, those on dialysis, again, cancer patients, immigrants from where? Pretty much the entire Asia country, Africa, including the Caribbean, Latin America, or the South America. Okay, so those are the places who have endemic TB. Okay, so people born there usually receive what? No, BCG. Okay, so myself included. So at birth, within 30 days of birth, we are given a BCG vaccine because we are exposed to TB, okay? Because it's endemic in the country. So all newborns in these countries are given BCG vaccine. Institutionalized people, so those who are in nursing homes, prisons, shelters, mental health facilities, anyone committed to a facility. Because what's the nature of facilities? I mean, what can you say? If you're in a facility, that means usually crowded, right? And you're exposed to people who have TB or any of these conditions, right? This will also include besides institutionalized. So let's say the projects. Okay, so they're usually crowded also, right? So tight, tight situations, like tight living situations, or healthcare workers. Because let's say you and me, we are nurses, we are exposed to these patients, right? And before we find out that they have TB, we've already been talking to the patient. We were all over this patient before we found out they had TB. And this will also include people who handle the specimens. So people whom we submit the sputum to, of course, they're exposed to the specimen, which are contagious. Okay. Any question on who can get it? So therefore, is everybody at risk for TB? Is this include everybody? No, it doesn't. It's specific. Who can get TB again? These people that are listed here. So again, the question, are everybody at risk for TB? No. You can be exposed to it. Of course, anybody can be exposed to TB, but do you get infected with it? Only these people listed here. Are we clear? All right. Yes, you were raising your hand, Wasu? Oh. I'm not testing this one. This is just how it was. Let's say you work in the hospital or in a long-term care facility, especially these are standards for TB. So in long-term care, they have a two-step PPD. Okay, they do it twice, 2 weeks apart. Unlike you guys have only one, right? Only unless you get the quantiferon gold. Okay, we'll get to the testing next. Manifestations first. So these are the classic manifestations of TB. Nothing really specific. So they have these symptoms usually over a month or longer. So they have the low-grade fever. Because it's slow growing, it's not going to cause a high fever. Okay, so it's a slow-growing infection. So it's not capable of inducing a high fever. So only low-grade fever, and then you have the night sweats, cough, again, usually over a month or longer. Fatigue and weight loss, unexplained weight loss. Once symptomatic, the patient will have the sputum will have pus in it and or may have blood. The most common test is still the PPD. So we implant the PPD, and when is it red?
48 hours later.
And because it's red twice.
The moment they inject and then.
No.
No, so no one.
So when you had who had PPD implanted here? 48 hours, and then when's the second check? 72 hours later. So it's red at 48 and 72-hour intervals. So on the sheet, it will be checked at 48, and then you come back again on the 72nd hour. That's the protocol.
I don't want that though.
It's checked twice. Unless they changed it, that they're only satisfied with one check, because there can be a late reaction.
You only check it once you get it done and then you send it back.
Okay. All right, what are we looking for a positive test? What do we call that? Okay. So it's the induration. So here's the wheel that they created. It's not the redness, okay? Redness doesn't count. It has to be induration. Okay? The raised area is what we measure. How much is the raised area? What is the diameter of the raised area? Well, we'll get to that because it varies per... So for this result, for testing purposes, I will use CDC. So just type in, search CDC PPD interpretation. And you'll see a link, like a fact sheet like this. Open that. And here's the reading. There are 3 sets of people who are considered positive. 3 groups of people, sorry. It's readable, right? Okay. So these 3 groups are positive. This is PPD. 5 or more is positive in these people who have HIV, immunocompromised people, organ transplants, okay, cancer patients. These are positive if they have a 5 millimeter induration, 5 millimeter or more. You know how I got to this page, right? You go to CDC, then type in CDC PPD interpretation. The first hit will be a fact sheet. It's also considered positive in 10 if the patients have these here. They are immigrants within the last 5 years, IV drug users, laboratory workers, people who live and work in homeless shelters, hospitals, prisons, nursing homes, psych mental health facilities, and people who have these conditions here: diabetes, on dialysis, malnourished, children younger than 5, which includes infants. Okay, what are they in order to be positive? How much before they positive? 10. How much for HIV and other immunocompromised people? 5. All other people who are not on this group nor on this group will have to be 15 or more to be positive. Any question? So on your exam next week, how is this tested? So I'll give you the patient's profile. Who is this patient? What do they do? Where do they come from? How old are they? And then I'll give you the induration. Then you decide, because you're the ones reading the PPD, whether this is positive or negative. Are we clear? All right. CDC, okay, because it's not always updated in the book, or I don't even know if it's even listed in the book. Okay. So how do we know you have TB? So if you have the symptoms, we will test you. So we have choices of testing. So the most common test is the PPD. A patient who had a history of or have recently received BCG vaccine within the last 10 years will of course turn positive on the PPD, correct? Because you've been exposed to the BCG. BCG contains the bacteria. So therefore, for those people, they have a choice to get a QuantiFERON Gold instead, or they can do another IGRA test, immunoglobulin assay test like QuantiFERON, because unlike PPD, the QuantiFERON Gold and the TB spot or IGRA test are not affected by BCG. Meaning, let's say I received BCG, right? By the way, BCG does not provide lifelong immunity. Like I got TB, okay? I got latent TB, but I was given the BCG. I turned positive. I was always negative from when I started working as a nurse. I was 21, so I was always negative. I came here when I was 28, and I was positive a year after. So first year I was here, negative. 1 year later for my annual, I tested positive. Okay, I had a large induration. So they confirmed it. But I had no symptoms. So therefore, I have what type of TB? Latent. So I got infected here, okay, not at home. So of course I thought, I don't believe this. There's TB left and right at home. I was never exposed. I come here. 1 year later, I got exposed to TB. Okay. Anyway, so I went through the 6 months treatment, and then that's it. Okay. So if you have recently received the BCG vaccine, to rule out whether the positive PPD is from the BCG or from exposure, we will do what test instead? No. Quantiferon gold. Because why? Quantiferon is not affected by a previous BCG exposure. All right. What do all of these tests say? Tell you. So PPD, quantiferon gold, T-spot test, IGRA. What do they all say? What does this say? A positive reaction does not mean that an active disease is in the body. So what do all they say? Let's say you're positive on quantiferon, positive on PPD, positive on T-spot. What does that mean? Do you have TB? No, not according to the statement, right? So what do they mean then? You were exposed to TB, but am I sick? No, we don't know if you have latent or if you have active TB. So how do we know if you have latent or active TB? What is therefore the basis? If these tests do not tell active disease. So what do we need? Okay, we need further testing. So one of them, let's say if the patient is asymptomatic like I was not symptomatic, so all they did was get a chest x-ray. So they did the x-ray, no cavities, no lesions. Then, do I have active TB? What do I have? I have latent. Okay, why did I have latent? Because my test came back positive. Are we clear? All right. If the patient has symptoms besides the chest x-ray, what else do I need? What will confirm the diagnosis? A sputum culture. So here, read the other tests again. Just like PPD, do they confirm active disease? No, they only confirm what? Exposure to the bacterium. So this is your prime diagnostic test. If the patient has symptoms, you get a sample and then you send it for culture. If the culture comes back with TB, then it's positive. So how do we know if the patient is already successfully treated? How do you confirm that treatment was successful? We get another sputum sample and they come back negative 3 times, 2 weeks apart, then you're cured. Are we clear? All right. Let's go to the drug therapy. Treatment is between 6 to 12 months. If it's latent, typically the recommended treatment is 6 months. If it's active, minimum 12 months, or it can be longer than 12 months. Any question? All right, so let's go to what are the drugs used. First of all, there are differences. There are 2 phases in the therapy. I'll get back to the drug after I explain the dosing and duration. Okay, so here we have, if you have active TB, you'll be given 4 drugs. If you have latent TB, you'll be given only 2 for 6 months. If it's active, then it'll be you can also be treated with 4 drugs for 6 months for active, as long as it's not a multi-drug resistant strain. All right. So these are the 4 drugs: INH, Refam, PZA or pyrazinamide, and ethambutol. There are 2 phases again. First phase is called the initial phase. 4 drugs are given during the initial phase. We will add vitamin B6, which is pyridoxine, because INH will drain your body's B6 levels, so we need to replace it. So that's why the 4 drugs plus vitamin B6. Okay. How long is the initial phase for 4 drugs? It's 8 weeks. How many drugs for 8 weeks? 4 drugs. Now the remaining, because it's technically 26 weeks, because it's 8 weeks plus 18 weeks. So that's about 6.5 months. So after the 8 weeks, what do I have left during the continuation phase? 2 drugs now. I'm down to 2. I will only be taking INH and rifampin for the remaining therapy. How many do I take again for the first 8 weeks? 4. How many do I take during the last 4 months or 18 weeks? Only 2. Now, why is this important to know? Who are these people again that will have TB, active TB? Are they like you and me in this room? Who are these people likely to be? The homeless, the HIV people, the IV drug users, okay? Psych mental health people. Are they likely going to take this easily? Like what? Because we haven't talked about the restrictions yet, okay? So let's go to the restrictions and then we'll come back to this question. Why it's important to explain to this patient, and they need to comply, by the way. Was this listed under CDC? TB? Yes, it's a highly communicable disorder, right? Can they force you to do treatment? Let's say you have a really, right-wing person and they say, I'm an American, I have rights. You can't force me to take those drugs. Can they do that? This is America. Can they do that? Can they do that? Yes or no? Yes, but can they be allowed to? No.
The CDC mandates, right?
Yes, the CDC has police power. They can institutionalize you. They can commit you involuntarily until you complete the treatment. Are we clear? All right, we can do that. Most of the time, though, they've never really gone to that extreme, because these people come to their senses eventually, unless of course the patient has, let's say homeless. Then we have to institutionalize them, okay, for the whole duration, because we really want to get rid of TB, right? Do you want them still in the subway or in the platform, out there with active TB? No, we want them treated, okay? And it's all paid for by
Government.
your taxes, okay? You're the ones paying for this. I don't think you'll complain, right? Will you complain? Like you're paying for people to get treated with TB, myself included. My treatment was free, including my testing. You paid for it. Thank you, by the way. Okay? I don't think you complain, right? Rather than people infecting you. Okay, so let's go to the drugs now. So think of the homeless person or IV drug user. They're taking 4 drugs, right? For how long? 8 weeks. And then 18 weeks or 4 months, 2 drugs. Okay. So the INH and Refam, PZA and ethambutol are the first 4. be taking it for 8 weeks. And then for the remaining 18 weeks, I'll be down to INH and rifampin only. Look at the side effects. 3 of them are hepatotoxic. They're harmful to the liver. Who are these people again? Okay. Are they also alcoholics? Yeah, they're also drinking, right? So telling them that you cannot take alcohol for how long? Total. Is that good news? It's hard, okay? It's not easy. And so therefore, since we know the drug causes liver toxicity, what do we monitor every month? Liver testing. What do we caution them not to take? Alcohol and or Tylenol, okay? So any nephrotoxic agent, alcohol, and other drugs as well. So other side effects for this is it causes neuritis because again, it depletes your vitamin B6. So we need to replenish that vitamin B6. Okay, so that's why we're taking vitamin B6 with the therapy. Next drug, rifampin. Same thing, it will cause liver toxicity. And what else does it do? It renders OCPs, oral contraceptive therapy, ineffective. So what do you do while taking this drug? Okay, you better use an alternative because the OCPs will be rendered ineffective. And what else does it do? What will it do to the urine and the eyes and tears? It will turn it orange, okay? Orange red. So is that dangerous? Not really, because it will just stain the fluids, okay? So it will stain what fluids again? Tears and the urine. Sweat, not so much, but the tears will be stained, okay? So your underwear, your clothes might get permanent stains, okay? So just caution them about that. So since these 2 drugs cause hepatic toxicity, what do we tell them to report? What's the earliest manifestation of liver toxicity? Jaundice, okay, so yellowing of the skin or yellowing of the sclera. What else? What will happen to the urine color if there is liver toxicity? The urine will turn dark. Like what color dark? Not really brown. It's like soda, like Coca-Cola, Pepsi. It will turn like that. Not really, because brown is like this brown. This is not Coke. It's darker. Okay, so it'll be like tea or Coca-Cola. Yeah, or coffee. Okay, dark. It'll turn dark. Is that reportable? Yes. How about the orange color of my urine? That's not reportable. That's harmless side effect. These 2 are just variations of rifampin. Okay, it's either rifampin or rifabutin or rifapentin. All right. So the 3rd drug is PZA, also causes hepatotoxicity, and it also causes a skin rash, or let's put it as photosensitivity. Okay, but hepatotoxic also. The last drug, do you see liver toxicity here? It does not. What does it say though? It causes? Okay, it can cause optic neuritis. So this is harmful to the eyes. So you need baseline eye testing, so we can see any changes while they're on this drug. So the patient's told to report any visual changes. Okay, No, whether they're getting blurred vision or color changes in their vision. All right. Any question? Oh, the parazinamide, besides the hepatic toxicity, it also causes hyperuricemia, also causes gout. So what will you advise the patient to do when you take this drug? Okay, a full glass of water, okay, or increase fluids while on this drug. So, is this easy for that patient who is IV drug user, homeless, probably an alcoholic, or probably have mental illness to take? Can we just trust them to, okay, here's your prescription, sir. Take it, okay? All right. You're a good boy, right? Will they do that? In the event that they do not comply or are not likely to finish therapy, we have we have this here. It was adopted by the CDC. We call it DOT, direct observed therapy. Right here, DOT. So DOT is not an original idea here. This is an original in the countries that we mentioned earlier. So the Philippines, Mexico, other Caribbean, African countries. So those countries invented DOT, okay? Because we have more TB there, and we have, just like here, we have non-compliant people, so we have to put them on DOT. So what is DOT? So fully funded program, we give you everything you need to make you comply, to encourage you, sorry, that's the better word, to encourage you to comply. Say, what are your issues? So we'll talk about the patient. Why, what would be your barriers? Why won't you want to comply with the therapy? Oh, it's a hassle. Yeah, I don't have money to come to, to get it. Oh, it's free, sir. What about how do I get there? Okay, we'll give you Metro cards. Okay, we'll give you vouchers. Okay, so to transportation vouchers. I'm hungry. Oh, we'll give you meal vouchers as well. Okay, so fully funded. So will it encourage the patient to comply? Yes. Okay, so again, fully funded. We just want you to finish the treatment. Okay, 6 months, finish the treatment. Can they drink alcohol? Will they drink alcohol though?
Yes.
Yes, they will. What do we do then? We just monitor the liver tests. Okay, so we'll just make sure we can't stop them. Okay, they're gonna drink. Okay? So you can just imagine what kind of 6 months that was for me. So I missed a lot of holidays, a lot of birthdays, fiestas, okay, while I was on 6 months therapy. No alcohol. Huh?
You said like if you were to then have that treatment.
Okay, I didn't have to miss work. Okay, so your question is very good. So when is a patient considered non-infectious? So when can I resume work? Since I had latent TB, was I infectious in the first place? Nuh-uh. So did I have to miss work? Not at all. I'm not contagious. However, if a patient has active TB, should they miss work? Yes, because they're contagious, but for how long? So here's the answer. People are considered non-infectious after when? 2 to 3 weeks of continuous medication therapy. So 2 or more weeks after treatment, at the beginning treatment, and of course my symptoms improve, can I go back to work? Yeah, I'm no longer infectious. Okay. As far as you getting clearance though, that's a different story. Some facilities, depending on your employer, let's say you have active TB. This guide is more for, let's say, when are you going to isolate yourself? Does that make sense? So this period here is more like, when can you go out of the house, instead of isolating. So you can be off isolation when? 2 weeks, 2 to 3 weeks of continuous medication therapy. No need for isolation. Okay, so you're not infectious anymore. But as far as when you can return to work, if you have active TB, it may take longer. It may take at least 6 weeks, because most employers will require 3 negative sputum cultures. And a sputum culture can only be taken every 2 weeks. Make sense? So I'd say 6 weeks before you can return to work, because that's a different story. But can you leave the house? Yes, after when? 2 to 3 weeks. You're okay. You're not contagious anymore. So what do we do with the family? This patient's family has been living with them this whole time. We had no idea yet that you had TB. What do we do? Test the family members the same way. Yeah, the same, just like the patient. Okay, yes, sir. I had a choice because what will happen to me, because it's in my body, right? It's in my body. I was exposed. So do I want to wait because I have latent now? Do you think it will stay latent when I'm 80 years old, 75? It won't be latent anymore because now am I immunocompromised? Yeah. It's still inside me though. But since I treated it, did I kill it? No. Yes, I killed it. I took 6 months of treatment. What did I do that for? If it didn't kill the organism? Yes, it did. Or same thing here. If you have active TB, we treated it for 6 to 12 months. What for is the treatment then? It's to eradicate the organism. So yeah, those people are treated. However, can they be reinfected?
Yes.
Of course.
Okay.
There's no immunity against bacteria, is there? No, we don't have antibodies against bacteria. We have antibodies against viruses, but not bacteria. Yes. Yeah, if you have TB again, which can happen, let's say, especially AIDS patients, yeah, they can have, but for AIDS patients, it's more like secondary TB, meaning it's their own TB that got, they got reinfected with their own TB. Yeah, but yeah, you can get infected again. If you develop the risk factors, who are those again who can get TB? Okay, these people here. Oh, no, that's not wrong term. Here. So if you belong here or if you develop this one day, then you're at risk for TB. Have you seen the commercials on these drugs, immunosuppressant drugs, let's say for Humira, Crohn's disease, psoriasis? What do they say? Before starting Enbrel, tell your doctor if you had TB or are prone to TB, right? Or you should be tested for TB. Yeah, because those drugs will cause immunosuppression and cause you to possibly get TB. So no, they have to warn you. All right, that's it for. So good luck on next week exam.